Welcome, future nurses, to the Deep Dive. You're stepping into one of the most incredible, intense, and frankly, life-changing fields, intrapartum nursing. Today, we're taking a deep dive into the foundational and critical aspects of intrapartum nursing care and complication management. This isn't just about memorizing facts, it's about being prepared for the dynamic reality of labor and birth, ensuring safety, comfort, and truly family-centered care.
And for you, as BSN nursing students embarking on your OB course and clinical rotation, this deep dive is designed to be your shortcut. We want you to grasp not just what to do, but why you do it, and how to anticipate those critical moments before they escalate. We'll connect the dots between supporting the beautiful, normal physiology of labor and birth and being ever vigilant for those sudden complications that demand rapid, evidence-based interventions from you, the nurse.
Exactly. We've gone through a comprehensive stack of material, and our mission today is to extract the most important nuggets of knowledge. We aim to give you a clear structure, memorable details, and those aha moments that will truly prepare you for your clinical practice. We want you to feel empowered by this information, not overwhelmed by its sheer volume.
So to map out our deep dive, we'll start with the fundamentals. Understanding the nurse's central role in supporting physiological labor and those crucial admission assessments. We'll explore how to distinguish between true and false labor and strategies to promote progress and prevent injury. Then we'll tackle common alterations like version, labor induction, and augmentation, preparing for the actual birth itself, including operative deliveries and cesarean births. Finally, we'll plunge into the high-stakes world of intrapartum complications and emergencies, recognizing the signs and knowing your immediate actions.
It's going to be an incredible journey, so let's unpack this deep dive into intrapartum nursing. When you think about birth, it's easy to focus solely on the physical process, the contractions, the pushing, the baby emerging. But it's so much more than that, isn't it? Birth is a profoundly life-changing event. It's an emotional, spiritual, and physical journey for the birthing person and their entire family. It's a moment that impacts them forever.
It absolutely is. And as an intrapartum nurse, you hold a truly unique position. You're not just supporting the normal, beautiful physiology of labor. You're also the vigilant protector. Because the fetus isn't directly observable, your role involves continuous assessment of fetal well-being, constantly monitoring those subtle cues, all while balancing the client's physical and emotional needs. It's a dual responsibility that demands both compassionate presence and precise clinical judgment. Your key responsibilities include assessing maternal and fetal status, meticulously documenting progress, providing unwavering comfort and support, and preparing for any potential interventions or emergencies. Even in what seems like a natural, uncomplicated process, some clients will require special procedures or additional monitoring to ensure the safest outcomes.
It's fascinating how much of our job starts even before a client steps foot in the hospital. As a new nurse, you'll find yourself on the phone, guiding nervous parents through distinguishing true from false labor. It's a real art, isn't it? Because knowing when to go to the hospital is a common source of anxiety. We provide guidelines, not strict rules. Generally, we advise coming in if they're having regular contractions about 5 minutes apart, lasting 1 minute for at least 1 hour. But it's vital to always emphasize that if they're uncertain, they should always come in for evaluation.
Absolutely. And there are other non-negotiable reasons to come in immediately. Any gush or even a trickle of fluid can indicate ruptured membranes or ROM, which is a critical sign needing immediate evaluation, regardless of contractions. Bright red bleeding, distinct from normal bloody show, which is usually darker and mixed with mucus, also demands prompt assessment. And a significant one, any noticeable decrease in fetal movement needs immediate assessment. Beyond these, we always tell clients to trust their gut feeling. If something just feels off, that intuition is paramount. Ultimately, your goal is to prioritize maternal and fetal safety. If there's bleeding, any fluid leakage, or decreased fetal movement, prompt evaluation is non-negotiable. It's always safer to be evaluated and sent home than to delay care when a complication might be unfolding.
First impressions truly matter, especially in the labor and delivery unit. That initial interaction sets the entire tone for the birth experience. Your presence as a nurse, how you convey confidence, competence, and caring can make all the difference. Even in a busy, high-stress environment, making eye contact, using a calm voice, or taking a few moments to communicate warmth and interest can profoundly influence how a client perceives their entire birth journey. It's not just about what you do, but how you make them feel.
Yes. Exactly. Building that rapport quickly is essential. Confidence and reassurance are key. You'll reinforce that intense contractions are a normal, powerful sign of progress in active labor, but you'll also maintain a vigilant eye for any complications. If possible, continuity of care assigning a primary nurse supports the client throughout their labor journey. When it comes to touch for comfort, always ask permission. It's a personal preference. Some clients welcome it, others find it intrusive. Respecting cultural values and incorporating preferences makes care individualized and meaningful. Use open-ended questions to clarify family expectations, whether they have a formal birth plan or just general preferences. Your priority here is to establish rapport quickly and demonstrate confidence in the client's ability to give birth, building a foundation of trust that's invaluable during the intensity of labor.
So once a client arrives, the admission assessment needs a focused, targeted approach. It's not about doing a full head-to-toe if birth is imminent. You need immediate, crucial information. This includes their chief complaint, of course, then the fetal heart rate, or FHR, maternal vital signs, and uterine contractions, specifically their frequency, duration, and intensity. You'll also ask about their perception of labor progress and their report of fetal movement, and note the presence of any high-risk conditions like hypertension, infection, bleeding, or ruptured membranes. This is about getting the most critical data quickly.
And here's a crucial safety point for your clinical practice. Never perform a vaginal exam with active, bright red vaginal bleeding beyond normal bloody show. This protects against worsening conditions like placenta previa, which could have devastating consequences. Now, if a client comes in grunting, bearing down, sitting on one buttock, or urgently exclaims the baby is coming, you must prepare for immediate delivery. In this scenario, you collect only essential information: client name, provider, relevant pregnancy history and complications, allergies, vital signs, and FHR. Notify the provider stat. Your immediate priority is clear. If birth is suspected, abbreviate assessment and prepare for rapid delivery, always ensuring maternal and fetal safety. In these moments, every second counts.
Beyond those initial checks, what are our constant lifelines in the labor room?
Absolutely. It's the continuous assessment of both maternal vital signs and the fetal heart rate. They're like two sides of the same coin. What happens with mom directly impacts baby. For instance, a rising maternal temperature could be the first clue to fetal tachycardia. You're monitoring for hypertension, which is 4 and 30/90 or greater, or any signs of fever, such as 38 degrees Celsius or 100.4 degrees Fahrenheit. Tachycardia, tachypnea, or hypotension could all signal infection, hemorrhage, or other serious complications. And with FHR monitoring, you're looking at the baseline rate, variability, accelerations, and decelerations. This is crucial for assessing fetal oxygenation status and detecting distress early. Once that initial focused assessment is complete, you move into essential admission procedures. This involves obtaining necessary consent forms for care, anesthesia, labor induction, cesarean birth, or even blood transfusion if there's a potential risk. You'll also review or order crucial lab tests, such as STI screening, blood type and Rh factor, and a complete blood count.
And crucially, establishing IV access with a large bore catheter is paramount. Think of it as a lifeline. Quick access to fluids or medications is absolutely essential. If complications like hemorrhage, preeclampsia, or an emergent cesarean birth arise, you want to be prepared before those moments hit. One of the most common calls a labor and delivery nurse gets is, "I think I'm in labor." And sometimes, after assessment, they're actually in what we call false or early labor. It's a tricky one, even for seasoned pros, isn't it? If there's no cervical change and membranes are intact, they're often discharged home. This can be frustrating for them, but it's a common part of the process.
It truly is. I remember a client, third baby, swore up and down this was it, only to find it was early labor. It's a huge source of anxiety because for them, it feels incredibly real. The challenge is distinguishing true from false labor, which is genuinely difficult. Careful assessment avoids unnecessary interventions while maintaining safety. Clients might feel frustrated or even embarrassed, which can make them reluctant to return if symptoms worsen, creating potential for delayed care. Anxiety and a lack of clear education are key issues that need to be addressed. Your goal is to ensure clients and their support persons can confidently describe the reasons to return to the hospital. Your interventions will focus on reassurance, acknowledge their disappointment, emphasize that early labor is difficult to recognize and that cervical changes like softening are still occurring, even if dilation hasn't progressed much. Latent labor can intensify suddenly.
This is where you, as the nurse, really empower them. Reinforce that early labor is a natural, necessary step. Encourage clients to view this time as progress, a vital part of their body preparing for birth, even if they're not being admitted just yet. When you're teaching them, review the guidelines for returning. Regular, strong contractions that get longer and stronger, ruptured membranes or leaking fluid, bleeding that's more than bloody show, or decreased fetal movement. And it's so important to reiterate that these are guidelines, not rigid rules. They should always return with concerns. It's safer to be evaluated and reassured than to delay care.
Your success here is measured by whether the client and support person can explain those reasons to return, confidently making safe decisions. Now, let's shift to true labor. This is confirmed by progressive cervical changes, either dilation or effacement, over 1 to 2 hours. Once true labor is established, your role shifts to ongoing monitoring, promoting progress, preventing complications, and supporting comfort. True labor is fundamentally identified by consistent cervical change. Observation over time is key, as initial assessments can sometimes be ambiguous.
When assessing the client in true labor, you'll be checking labor progress through vaginal exams. But remember, these are done as needed due to the infection risk. You're looking at dilation, effacement, station, and fetal presentation. If the client reports intense rectal pressure or an urge to push, you should inspect the perineum for crowning and then perform a sterile vaginal exam. Contractions can be assessed by palpation or with electronic fetal monitoring, EFM. Normal uterine activity is 5 or fewer contractions in 10 minutes, averaged over 30 minutes. Excessive activity can actually reduce placental blood flow and gas exchange, potentially leading to fetal acidemia, where the baby isn't getting enough oxygen. For low-risk clients, the frequency of assessment changes by stage. Hourly in the latent phase, less than 4 centimeters, every 30 minutes in the active phase, and every 15-30 minutes in the second stage, depending on active pushing or passive descent.
Right. And here's an important point for your practice. Always validate contraction strength and resting tone by palpation, even when using external monitoring. Devices can sometimes be misleading, and your hands provide crucial direct information. Beyond contractions, you're tracking intake and output, recording all oral and intravenous intake and urinary output. Assess bladder fullness every 2 hours or more, as clients may not sense the urge to void, which can actually impede labor progress by taking up space in the pelvis. Client response to labor varies widely. Anxiety, for example, increases the release of catecholamines, which are stress hormones that can actually interfere with effective uterine activity. You'll observe for signs of coping, such as focused inward attention, rhythmic breathing and movement, relaxation between contractions, or verbal affirmations like, "I can do this." Conversely, signs of not coping include repeated requests for pain medication, ineffective relief, tension, panic, crying, trembling, or verbalizing, and inability to continue.
This is where your nursing support truly shines. You'll support coping with both non-pharmacologic strategies, like position changes, hydrotherapy, or massage and pharmacologic strategies, like epidural or IV pain meds, always doing so without disrupting labor progress or fetal well-being. And don't forget the support person. Labor can be incredibly stressful for partners, too. They might experience anxiety, helplessness, or fatigue. Reassurance from the nurse strengthens their ability to provide effective support and contribute significantly to a positive birth experience. Always respect cultural expectations regarding their involvement.
Moving to fetal assessments, FHR is continuously assessed with intermittent auscultation, or EFM, with frequency depending on risk and stage. FHR should also be checked before and after interventions like rupture of membranes, ambulation, or anesthesia. Now, amniotic fluid is a critical assessment when membranes rupture, whether spontaneously (SROM) or artificially (AROM). Your first priority is always to assess FHR immediately. Why? To rule out umbilical cord prolapse, a time-critical emergency where the cord slips below the baby's head and gets compressed. Variable or prolonged decelerations or bradycardia on the monitor may signal this. Your second priority is to evaluate the fluid for color, odor, and quantity. Normal fluid is clear, possibly with vernix, and has a mild odor. Green fluid may indicate meconium passage and fetal stress, while cloudy, foul-smelling, or yellow fluid suggests infection. Both polyhydramnios, too much fluid, and oligohydramnios, too little fluid, carry risks for fetal complications.
Yeah, if we think about the bigger picture, complications associated with ruptured membranes include, as you mentioned, umbilical cord prolapse. There's also an increased risk of infection, especially after 24 hours post-rupture. And in some cases, a rapid loss of amniotic fluid volume can even trigger partial placental separation, known as abruptio placentae, risking fetal oxygenation and maternal hemorrhage. When assisting with an amniotomy, which is the artificial rupture of membranes, your nursing considerations include obtaining a baseline FHR, positioning absorbent underpads, reassuring the client that it's not painful beyond a regular vaginal exam, and preparing sterile supplies. The provider confirms dilation, effacement, station, and presentation, and may defer if the presenting part is high or not, head down, again, due to that prolapse risk. And immediately after amniotomy, you must assess the FHR for at least 1 full minute to identify any cord compression or other abnormalities. That immediate check is absolutely non-negotiable for fetal safety.
As labor progresses, you'll inevitably encounter situations where labor might be prolonged or slow, and helping things along becomes a shared goal for the entire care team. Early identification of slow or stalled labor allows you to implement supportive strategies and prevent complications before they escalate. Your goal is for the client to use effective techniques to support progress, including position changes, pain management, and appropriate breathing and pushing techniques.
And here's a huge factor: positioning and movement. Encourage clients to assume any comfortable position other than lying flat on their back and to change positions frequently. Movement and upright positions can help decrease pain, improve circulation, strengthen contractions, shorten labor, and reduce perineal trauma. For example, squatting or using a squat bar enlarges the pelvic outlet and uses gravity. A peanut ball placed between the legs is incredibly helpful for clients with epidurals, shown to decrease labor length and reduce cesarean birth risk. Side lying or semi sitting positions promote pelvic opening and reduce pressure on major nerves. And frequent position changes, even every 20-30 minutes, are vital even with epidural anesthesia. Avoid prolonged supine positioning at all costs, as it can compromise circulation to both the mother and the baby.
Right. The first stage of labor can be long and discouraging. As nurses, you need to provide regular updates on cervical progress and fetal status, offer education on pain management, and reinforce that the latent phase can be lengthy, but typically accelerates after 5 centimeters dilation. If a client feels an urge to push before full dilation, teach them short exhalations or panting to avoid cervical swelling or lacerations, which can prolong labor. In the second stage, from complete dilation to birth, clients need guidance on when to push, usually with a natural urge, and positions for pushing, such as squatting, sitting on a birthing ball, or supported upright positions. Effective pushing techniques involve coordinated breathing, abdominal engagement, and relaxation of the perineum. We often encourage laboring down or passive descent, allowing the baby to naturally descend without active pushing. This can decrease maternal fatigue, shorten active pushing time, reduce perineal trauma, and improve outcomes.
When it comes to pushing methods, encourage spontaneous pushing that matches contractions. Teach clients to push with abdominal muscles while keeping the face, neck, and perineum relaxed. Recommend short, repeated pushes of 6 to 8 seconds instead of prolonged breath holding, often called valsalva or purple pushing, which can reduce placental blood flow and increase maternal fatigue. Encourage rest and sighing breaths between contractions. Your priority here is to support effective pushing while minimizing exhaustion and preventing fetal compromise. The evaluation of labor progress isn't just about the clock. It's successful if the client uses a variety of effective strategies like frequent position changes, appropriate breathing and pushing, and comfort measures. This collaboration between the nurse, the client, and the entire support team is what truly promotes labor progress.
Now, equally important is preventing injury. Assessment is continuous throughout the second stage. You'll observe the perineum for birth preparations. For a nullipara, someone giving birth for the first time, preparations usually happen when the fetal head crowns. But for a multipara, who has given birth before, preparations occur sooner, often when the cervix is fully dilated and the head is engaged, even before crowning is visible. This timing is crucial. Your priority is to anticipate and minimize risks for maternal injury immediately before, during, and after birth, because the client is especially vulnerable in that second stage due to altered sensations from pressure or anesthesia, positioning changes, or unexpectedly rapid labor progression. Ultimately, we want to make sure our clients avoid preventable injuries like muscle strains, blood clots, nerve damage, or severe perineal tears.
Interventions for injury prevention often start with positioning for birth. Gravity-advantaged positions promote pelvic outlet expansion and reduce injury. Think upright positions like squatting, standing, kneeling, or sitting. Forward-leaning positions increase pelvic diameter. Hands and knees is incredibly useful for occiput posterior positions or wide fetal shoulders. Semi-recumbent or sitting in a birthing bed provides gravity advantage while being less tiring. Even with epidural analgesia, frequent repositioning is vital. If stirrups are used, legs should be raised and lowered together, not spread too widely, and the popliteal space should be padded to reduce the risk of thrombus or peroneal nerve injury. And always avoid prolonged supine positioning. Keep the upper body in a semi-Fowler's or sitting position to promote circulation and reduce the risk of supine hypotension.
During late second stage labor, you'll be observing the perineum for fetal head extension and those perineal changes that cue birth preparations. A common, urgent sign of imminent birth is the client stating, "The baby's coming." Your priority is to stay alert for these signs and respond promptly to ensure maternal and newborn safety. You should calmly inspect the perineum and be prepared to support the infant's head and body with gloved hands if birth occurs quickly before the provider arrives, while directing the support person to summon additional assistance. The evaluation of injury prevention is both immediate and ongoing into the postpartum period. The provider will assess and repair any perineal lacerations after delivery, But you, the nurse, continue monitoring for complications such as muscle strain, blood clot formation, or nerve injuries that may not appear until hours or days after birth. Your role in injury prevention is ongoing.
As we move into interventions and alterations in labor, one of the first things we might encounter is aversion, which is all about turning the fetus into a more favorable position for vaginal delivery. This intervention is used when the fetus is in a breech, transverse, or oblique lie, and the goal is to get them into a cephalic or head-down presentation. This can significantly increase the chance of a vaginal birth and potentially help avoid a cesarean. The most common method is external cephalic version, or ECV, where the provider applies pressure to the client's abdomen to gently guide the fetus. Internal version is rarely performed, typically only for a second twin after the first has already been delivered. The indications are pretty clear: breech, transverse, or oblique presentations, and a desire to reduce the risk of a cesarean birth. It's generally most successful when attempted for a transverse lie.
Now, it's just as important to know when not to do an ECV. You must carefully evaluate both maternal and fetal conditions to ensure safety. It's avoided if a vaginal delivery is unlikely or if conditions increase the risk of harm, such as uterine abnormalities or scarring from previous surgeries, placenta previa, placental abruption, or third trimester bleeding. Other contraindications include disproportion between fetal size and maternal pelvis, multifetal gestation, except sometimes for a second twin, oligohydramnios, low amniotic fluid, ruptured membranes, or neutral cord around the neck. Also, if there's intrauterine growth restriction, uteroplacental insufficiency, or if the fetal head is already engaged in the pelvis, ECV is typically not performed. While complications are uncommon, they can be serious, including umbilical cord compression, placental abruption, mixing of maternal and fetal blood leading to RH sensitization, or fetal distress requiring an emergency cesarean delivery. Most FHR changes during ECV are temporary and resolve once the manipulation stops.
Because complications can occur, ECV is always performed in a facility prepared for immediate cesarean delivery. This procedure is typically timed at 37 weeks or later, but before labor begins. An ultrasound confirms fetal position, placental location, amniotic fluid volume, and overall fetal well-being. A non-stress test, or NST, or biophysical profile, BPP, is performed both before and after the procedure. The client might receive a tocolytic medication which relaxes the uterus or regional anesthesia for comfort. And critically, Rh-negative clients are given Rh immunoglobulin, or RhIg, after the procedure to prevent sensitization.
Your nursing role here is multifaceted. First, provide comprehensive information. Ensure informed consent covers the ECV, any medications, anesthesia, and the potential for a cesarean birth. Teach them about the purpose and possible side effects of tocolytics or anesthesia, and verify that all surgical and newborn consents are signed in case an emergency delivery becomes necessary. Then you focus on promoting client and fetal health. This means admitting and preparing the client as if for labor or a cesarean, having them NPO for at least 6 hours, starting 4 access, obtaining baseline vital signs and FHR, and continuously monitoring fetal well-being throughout the procedure. Observe the client and fetus for at least an hour post-procedure, provide RHRG if indicated, and teach them signs of labor or complications to report after discharge. Your priority is to notify the provider immediately if abnormal FHR patterns, category 3 or 3, occur, or if persistent pain after ECV signals a possible placental abruption which requires urgent evaluation. Clear communication and reassurance are essential to reduce fear during this high-stakes procedure.
The evaluation of care during aversion is based on stable maternal vital signs, FHR returning to baseline with moderate variability in accelerations, the absence of complications like bleeding or severe pain, and the client's ability to verbalize understanding of signs of labor and when to return to the hospital.
Now, let's discuss labor induction, which initiates labor, and augmentation, which strengthens an existing labor pattern. Success is more likely when the cervix is favorable, typically dilated to at least 2 centimeters and effaced. For elective procedures, it's safest at 39-40 weeks after gestational age has been confirmed. Indications for induction can be medical, such as a compromised intrauterine environment, premature rupture of membranes, PROM, at or near term, post-term pregnancy beyond 42 weeks, chorioamnionitis, uterine infection, hypertensive disorders, placental abruption, worsening maternal conditions, or fetal demise. Elective induction might be considered at 39-40 weeks with verified dating or for clients with a history of precipitous labor and a long distance to the hospital. Augmentation is considered when spontaneous labor slows or stalls despite apparently adequate contractions, and non-pharmacologic stimulation like nipple stimulation has been attempted first.
So, your priority here is to verify the indication, gestational age, and cephalic presentation before initiating any induction or augmentation. There are also clear contraindications and cautions. Absolute or relative contraindications include placenta previa or vasoprevia, umbilical cord prolapse, transverse lie or other malpresentations, active genital herpes, and a prior classical cesarean incision or significant fundal uterine surgery. If a contraindication to vaginal birth exists, you do not induce or augment. Other situations require individualized evaluation, such as one or more prior low transverse cesareans, breech presentation, uterine overdistension, polyhydramnios, significant maternal cardiac disease or severe hypertension, a high unengaged presenting part with suspected cephalopelvic disproportion, or an inability to adequately monitor FHR, or an existing Category 3 FHR pattern.
The risks associated with these procedures are important to understand. They include excessive uterine activity, also known as tachysystole, which can reduce placental perfusion and lead to fetal hypoxemia. There's also the risk of uterine rupture, which increases with overdistension, a prior uterine scar, or tachysystole. Water intoxication can occur with hypotonic 5B fluids or high oxytocin rates, and the risks of infection, chorioamnitis, cesarean birth, and postpartum hemorrhage. Elective term inductions, especially with an unfavorable cervix, have a higher risk of cesarean and neonatal respiratory complications. Your priority is to use the Bishop score, which assesses cervical dilation, effacement, consistency, position, and fetal station to estimate readiness. A score of 8 or higher is generally associated with a higher likelihood of vaginal birth. You must document that Bishop score before choosing a method for cervical ripening or induction.
Cervical ripening is recommended if the Bishop score is 6 or less before a planned induction. Pharmacologic methods include PGE2, dinoprostone, in vaginal gel or timed-release inserts, and PGE1, misoprostol, which is often used off-label. Remember, misoprostol should not be used in clients with a prior cesarean or major uterine surgery due to uterine rupture risk. The main adverse effect for all prostaglandins is tachysystole, requiring continuous FHR and uterine activity UA monitoring. Mechanical methods like transcervical balloon catheters, membrane stripping, or hygroscopic dilators generally have a lower risk of tachysystole. When considering ripening methods, prioritizing mechanical options is important when reducing tachysystole risk is particularly important, such as in a trial of labor after cesarean or TUOLAC.
When administering oxytocin, which is a common medication to induce or augment labor, the general principles are to dilute it in an isotonic solution, run it as a secondary infusion on a pump, and conduct it to the proximal IV port for rapid discontinuation if needed. You must establish baseline FHR and UA prior to initiation. Protocols vary for starting and titration, either low dose or high dose, but the goal is to achieve an effective labor pattern contractions every 2-3 minutes, lasting 40-90 seconds, with at least 60 seconds of relaxation in the first stage, while avoiding tachysystole. Prolonged exposure can desensitize receptors, so consider reducing the rate once in active labor and after ROM to maintain efficacy and reduce adverse effects. You must ensure continuous electronic monitoring of FHR and UA throughout the oxytocin infusion.
When observing the fetal response, you need to assess the FHR for at least 20 minutes before starting oxytocin and continuously monitor for any concerning patterns. If you see concerning FHR changes with tachysystole, your immediate steps are crucial. Stop the oxytocin, position the client in a sideline position, give an IV fluid bolus of at least 500 milliliters, and consider oxygen at 10 liters per minute via non-rebreather mask. Then notify the provider and anticipate an order for terbutaline, a medication that relaxes the uterus if there's no improvement. As for uterine activity, your target is contractions every 2-3 minutes, lasting 40-90 seconds, with a relaxation time of at least 60 seconds in the first stage or 45-50 seconds in the second stage, and a soft resting tone. Tachysystole indicators include more than 5 contractions in 10 minutes, contractions lasting over 120 seconds, inadequate resting intervals, or an elevated resting tone. If tachysystole occurs with a normal FHR, you might try a lateral position, IV bolus, or reducing stopping oxytocin. If FHR is abnormal, stop oxytocin immediately, reposition, give an IV bolus and oxygen, notify the provider, and prepare for tocolysis.
Right. When it comes to maternal monitoring, check vital signs every 30-60 minutes, or with each oxytocin rate change, and temperature every 2 hours if membranes are intact, or hourly after ROM. Monitor intake and output closely for fluid retention and signs of water intoxication, which can manifest as headache, behavioral changes, crackles in the lungs, or changes in blood pressure and heart rate. Anticipate earlier and stronger discomfort with induced labor, so proactively offer both non-pharmacologic and pharmacologic pain management options. Accurate, timely documentation of FHRUA, oxytocin dose changes, maternal status, and all interventions is absolutely essential for safety. Postpartum, there's an increased hemorrhage risk because prolonged oxytocin exposure can contribute to uterine atony, meaning the uterus doesn't contract effectively.
And here's a critical nursing action. Promptly address uterine atony and escalate per your facility's postpartum hemorrhage, or PPH protocol. You also need to be aware of the safety check signs of excessive uterine activity. Contractions over 120 seconds, less than 60 seconds of relaxation in the first stage, or less than 45-50 seconds in the second stage. A firm resting tone, or more than 5 contractions in 10 minutes. The evaluation is successful if a safe, effective contraction pattern is achieved without tachysystole, FHR remains reassuring, the client tolerates the process with comfort, and postpartum, the uterus remains firm with expected lochia. Your overarching priority is to balance labor progress with maternal-fetal safety through vigilant assessment, timely interventions, and clear interprofessional communication. Now we arrive at the moment of birth and the immediate postpartum period, often referred to as a fourth stage of labor. As the nurse, your responsibilities during birth involve coordinating maternal, fetal, and newborn needs. This means preparing a sterile delivery table, pre-warming all newborn equipment and linens, performing perineal cleansing, continuing ongoing assessments of maternal status and FHR, and supporting the client and partner during those final pushing efforts. After birth, you'll provide initial newborn care and assessment and administer uterotonics, usually oxytocin, to help the uterus contract and reduce blood loss.
It's crucial that at least one clinician certified in neonatal resuscitation must be present at every birth, with a dedicated role for the newborn. The intrapartum nurse, meanwhile, continues to support the birthing client and provider. For you, it's vital to use full personal protective equipment, including eye protection. Newborns are often covered with amniotic fluid, blood, and vernix, so gloves and appropriate barriers are required until the infant's first bath. Before crowning, verify the availability and function of all birth and resuscitation equipment. This means the radiant warmer is on and pre-warmed, suction and bag mask devices are ready with appropriate masks, oxygen and air are available, the pulse oximeter is functioning, and a clock or timer is at hand.
Moving to alterations in the birth process, we sometimes need operative vaginal birth, using instruments like forceps or a vacuum extractor. These instruments assist the descent or rotation of the fetal head and augment pushing efforts. While their use has declined, these remain essential when a timely vaginal birth can improve outcomes for either the mother or the fetus. Indications include shortening the second stage due to maternal exhaustion, ineffective pushing, infection, or specific cardiac or pulmonary conditions. Fetal reasons might include failure of rotation or descent, a concerning FHR pattern near birth, or a suspected partial abruption where a rapid vaginal birth is feasible. Your priority is to confirm all prerequisites: a fully dilated cervix, ruptured membranes, vertex presentation, head down, known fetal position and station, an engaged head, and adequate anesthesia.
Contraindications are critical here. Cesarean birth is preferable when it's faster or safer. Forceps or vacuum should not be used for breech, face, or brow presentations. Transverse lie, an unengaged head, suspected cephalopelvic disproportion, CPD, an incompletely dilated cervix, fetal bone demineralization or bleeding disorders, or extreme prematurity, generally less than 34 weeks for a vacuum. Institution policies commonly limit vacuum attempts, for example, to 3 pop-offs, and they often discourage switching to forceps after a failed vacuum due to the increased risk of injury. Risks for the mother include vaginal, cervical, or perineal lacerations, hematoma, pelvic floor injury, anal sphincter disruption, and infection. For the newborn, risks include scalp and facial abrasions, cephalohematoma, a collection of blood under the scalp bone, subgaleal or intracranial hemorrhage, facial nerve injury, and jaundice. A vacuum may also cause a transient chignon, which is a swelling on the scalp, but this is expected and usually resolves.
Your priority during these procedures is continuous FHR monitoring during both application and traction of the instruments. You must stop and reassess if there are non-reassuring FHR patterns, poor descent, or repeated cup detachments. The technique is provider-led, but your nursing support is vital. This involves verifying presentation, position, station, and anesthesia. For forceps, the blades align over the cheeks and parietal bones, with traction synchronizing with contractions. For a vacuum, the cup is applied over the flexion point, and suction is created with a hand pump, with traction applied intermittently with contractions. And before the procedure, you'll empty the bladder with a sterile catheter, place the correct instrument set according to provider preference, and ensure the neonatal team is present and ready.
Immediate post-birth care for the mother involves inspecting for trauma, especially hematoma formation, which can cause increasing pain, pressure, or asymmetric swelling. Cold therapy to the perineum is used for the first 24 hours, transitioning to warm sitz baths thereafter. You'll administer uterotonics and frequently assess the fundus and lochia. For the newborn, assess the scalp and face for abrasions, lacerations, asymmetry, cephalohematoma, or signs of subgaleal hemorrhage, which presents as diffuse, fluctuant scalp swelling that crosses suture lines, pallor, and tachycardia. Thermoregulation is key. Keep the baby warm and do not apply cold to the neonatal scalp. Document a chignon after vacuum as an expected, self-limiting finding, and monitor bilirubin if bruising is extensive. Remember, subgaleal hemorrhage is rare but life-threatening. Escalate immediately for pallor, tachycardia, increasing head circumference, or lethargy. For parent teaching, explain that minor bruising or a vacuum chignon typically resolves. Review perineal care, expected soreness, and when to call for concerns like increasing pain, swelling, fever, heavy bleeding, or foul lochia. If birth is imminent before the provider arrives, remain with the client. Support the emerging head and body with gloved hands. Call for help. Note the exact time of birth and proceed with standard immediate newborn care and maternal safety measures.
Now let's briefly touch on episiotomy. This is a surgical incision of the perineum. It's no longer routine as its benefits, like reduced pain or protection from pelvic floor dysfunction, have not been definitively demonstrated. The decision is individualized and may be indicated for specific needs like rapid resolution of shoulder dystocia, operative vaginal birth, or breech delivery. A midline episiotomy increases the risk of more severe third or fourth degree tears, while medial-lateral incision, though potentially more painful, may reduce anal sphincter injury. Risks include infection, more severe lacerations, longer-lasting perineal pain, and increased likelihood of laceration in subsequent births. In nursing considerations, strategies for avoiding or limiting episiotomy include upright pushing, delayed pushing until the natural urge, open glottis pushing, and perineal massage and stretching. Immediately after birth and postpartum, you'll assess the perineum using RITA, redness, edema, ecchymosis, discharge approximation, apply cold therapy for the first 24 hours, then warmth, and inspect for hematoma or edema.
Your priority is to provide clear perineal care teaching, including hygiene and pain control, and what to call for concerns. You'll also screen bowel and bladder function and support stool softeners, fluids, and fiber to protect the repair. Now let's shift to cesarean birth or C-section. Rates remain high, driven by factors like induction in nullipares with an unfavorable cervix, older maternal age, higher BMI, persistent breech presentations, medical legal concerns, and client request. Reducing primary cesareans, especially for labor dystocia, and offering appropriate VBACs or vaginal birth after cesarean helps to reduce overall rates. Indications for a C-section are varied, including labor dystocia or cephalopelvic disproportion, non-reassuring FHR patterns, hypertensive disorders like preeclampsia, maternal conditions where labor is unsafe, prior classical uterine incisions, placenta previa, placenta covering the cervix, prolapsed cord, malpresentation, or multiple gestation. Each additional cesarean increases future risks of placenta previa, placenta creta, abnormal placental adherence, and surgical adhesions. It's important to counsel clients longitudinally about this.
Regarding VBAC and TOLAC, successful VBAC offers lower maternal morbidity and improved future pregnancy outcomes. However, a trial of labor after cesarean TOLAC carries a small but real risk of uterine rupture, especially with prior vertical or classic incisions. Appropriate candidates typically have 1 or 2 prior low transverse uterine incisions, no other contraindications to vaginal birth, and are in a facility capable of immediate emergency cesarean, continuous FHR monitoring, and rapid blood product availability. Counseling should balance the benefits, like fewer complications and shorter recovery, against the risks, such as a failed TOLAC leading to higher morbidity than a planned repeat cesarean, and the rare but serious risk of uterine rupture. Your priority is to confirm the prior uterine incision type from the operative record, ensure continuous EFM, avoid misoprostol for cervical ripening and TOLAC, and review rapid response plans with the team.
For TOLAC management, external cephalic version is not contraindicated with a prior low transverse cesarean. Epidural analgesia is acceptable. Oxytocin can be used for induction or augmentation, but favoring mechanical ripening methods, like a transcervical balloon, is often preferred if the cervix is unfavorable. Crucially, avoid misoprostol for ripening and TOLAC. Most authorities recommend continuous electronic fetal monitoring. It's fascinating how the earliest sign of uterine rupture is often a change in FHR, such as recurrent late or variable decelerations or bradycardia, rather than maternal pain. Maintaining continuous EFM and escalating immediately for concerning patterns is paramount. If induction is needed for TOLAC, start with mechanical ripening when appropriate, use conservative oxytocin titration, and have a clear, pre-briefed plan for an emergent cesarean.
For the cesarean technique and intraoperative overview, there are skin incisions, low transverse or vertical, and uterine incisions. Low transverse is preferred due to lowest rupture risk, low vertical or classic, which has the highest future rupture risk. The birth sequence typically involves the uterine incision, rupture of membranes if intact, suctioning, delivery of the baby, often with delayed cord clamping for 30-60 seconds when feasible, then removal of the placenta, administration of oxytocin, and layered closure. Promote early skin-to-skin contact and support delayed cord clamping when clinically appropriate.
We also have enhanced recovery after cesarean, or ERT protocols. This is a nursing map to optimize recovery. Preoperatively, typically 30-60 minutes before the operating room, clients are NPO per policy, receive an H2 blocker or antacid, acetaminophen, and complete consents. An 18-gauge scree is started, labs are drawn, sequential compression devices, SCDs, are applied, and antimicrobial skin wash is performed. Remember to place a wedge under the hip for aortic cable compression prevention during preoperative care, intraoperatively, and during transfers. Intraoperatively, antibiotic prophylaxis is given within 60 minutes of incision, the abdomen is prepped, regional anesthesia is preferred, and normothermia is maintained. Continuous maternal monitoring and fetal tones are documented pre-incision, and the neonatal pathway is ready. Postoperatively, multimodal analgesia is used, with early oral intake, ambulation, and catheter removal. Nausea and vomiting prevention and glycemic control are also key, along with ongoing assessments of the fundus, lochia, vitals, urine output, incision, and DVT prevention.
Your priority in the postoperative phase of a C-section is frequent checks for postpartum hemorrhage, focusing on fundal tone and height, and lochia amount and clots. You need to respond quickly to atony with uterotonics and your facility's PPH protocol. For nursing considerations in cesarean care, emotional support is vital. Validate feelings like grief, guilt, or anxiety, and use calm, confident communication. Encourage partner presence with regional anesthesia. Teaching points include what to expect with hair clipping, Foley catheters, IVs, monitors, and the OR environment. Explain sensations with regional anesthesia, the PCU routine, and homegoing instructions for incision care, warning signs, activity progression, pain management, and lactation support. And for promoting safety, confirm equipment function. Carefully position the client. Ensure lateral transfers, and meticulous documentation of counts, timeouts, and antibiotic timing. Specifically, ensure antibiotics are given within 60 minutes pre-incision, SCDs are on, the wedge is in place, and the neonatal team is present before skin incision.
After the baby is born, we enter the fourth stage of labor, which is the first 1-2 hours after birth. The focus here is on preventing complications, promoting comfort, and supporting safety for both the client and the newborn. Observing for hemorrhages is the most critical risk during this time. You'll assess temperature at the start of fourth stage care and then check blood pressure, pulse, and respirations every 15 minutes for the first 2 hours. A rising pulse is often the earliest sign of blood loss, while falling blood pressure is a late sign. Decreased or absent urine output can indicate hypovolemia. You must always interpret vital signs in the context of uterine tone, lochia, and urine output. These give you a fuller picture.
The uterine fundus must contract firmly to compress blood vessels at the placental site. Assess fundal tone, location, and height with each vital sign check. A soft or boggy uterus suggests uterine atony and a high risk for hemorrhage. Your intervention for a boggy fundus is to support the lower uterine segment with one hand, massage the fundus until it's firm, and expel any clots. If the fundus is high or shifted, check for a full bladder, as this can displace the uterus, preventing contraction and increasing bleeding risk. Assist the client to void or catheterize if they're unable. Check lochia with every vital sign and fundus assessment. Normal is a steady flow with small clots. Excessive is pad saturation within an hour or pooling. Large clots or a foul odor are abnormal. If hemorrhage is suspected, identify the cause, which is often uterine atony, and keep the client NPO until the provider evaluates.
You'll also inspect the perineum and labia for bruising, swelling, or hematoma formation. Small hematomas are usually controlled with ice packs, but large or expanding ones require immediate provider notification. Remember, hematomas may cause severe perineal pain not relieved by analgesics and can lead to concealed blood loss. For promoting comfort, address afterpains and perineal trauma with ice packs, oral analgesics, and regular bladder emptying. Offer warm blankets for chills and warm fluids. For mobility and safety, assess leg strength and sensation, especially after regional anesthesia, check for dizziness, and assist with ambulation until stability is confirmed. After a cesarean birth, care includes all these assessments plus additional surgical recovery monitoring. Vital signs, ECG, respiratory effort, oxygen saturation, return of motion and sensation, level of consciousness, incision dressing and drainage, urine output, IV site, and SED function for DVT prevention. Have naloxone or Narcan available if epidural opioids were used, due to the risk of delayed respiratory depression.
Finally, during this fourth stage, we promote early family attachment, often called the golden hour. This first hour after birth is ideal for fostering parent-infant attachment. Healthy newborns are alert and responsive, creating an opportunity for lasting bonding. As nurses, your role is to provide privacy while maintaining safety, allowing private time together but maintaining unobtrusive observation. Many newborn assessments can actually be done skin to skin. You'll encourage immediate and sustained skin to skin contact, which offers benefits like improved thermoregulation, stabilization of heart and respiratory rates, enhanced breastfeeding initiation, and strengthened bonding. If breastfeeding is chosen, assist the client to latch the newborn during this first hour. Early breastfeeding promotes uterine contraction, reduces postpartum bleeding, and starts milk production.
Family integration is also key. When the parents are ready, invite siblings and other family members to visit, providing practical support like a stool at the bedside. You'll observe for signs of early attachment, such as tentative fingertip touch progressing to palm contact, full enfolding, eye contact, and affectionate verbalization. These early signs should be encouraged and reinforced as they reflect healthy attachment. It's also crucial to consider cultural values. Some cultures view intense newborn attention as unlucky, sometimes referred to as the evil eye. Nurses must respect and adapt to cultural practices, balancing safety with culturally sensitive support.
As we move into the high-stakes world of intrapartum complications and emergencies, it's crucial to remember that while most labors proceed normally, nurses must always be prepared for prolonged, difficult, or hazardous situations. Complications often overlap. For example, dysfunctional labor increases the risk of infection. Your role as a nurse is paramount. Prompt recognition, timely interventions, continuous monitoring, and providing emotional support and reassurance to the client and family. We categorize these complications as problems with the powers, contractions or pushing, the passenger, the fetus, the passage, the maternal pelvis and soft tissues, or the psyche, the emotional state.
Let's start with dysfunctional labor, which is any labor pattern that doesn't result in normal progress, whether it's prolonged or shortened. If it's unresolved or compromise occurs, such as abnormal FHR patterns, fetal acidosis, or maternal exhaustion, operative birth may be needed. When we talk about problems of the powers, we're looking at ineffective contractions, those that are uncoordinated, weak, or insufficient for cervical change or fetal descent. When contractions become ineffective, it's like a car spinning its wheels, lots of effort, no forward motion. This could be due to anything from maternal fatigue to an overdistended uterus from something like polyhydramnios. Your key is to quickly spot patterns like labor dystocia, where contractions are weak and infrequent. We'll often try simple fixes first, like rehydration or position changes, but if things are getting too intense, say, over 5 contractions in 10 minutes, we're looking at tachysystole, which can actually stress the baby. In those cases, stopping oxytocin and repositioning is your first move.
Your nursing considerations here include continuous FHR and contraction monitoring, supportive communication, encouraging movement and relaxation, and educating the client about interventions.
Moving to problems with the passenger, fetal variations are key contributors to dysfunctional labor. Fetal size, for instance, in cases of macrosomia, generally over 4,000 grams, can lead to cephalopelvic disproportion and uterine overdistension, which reduces contraction strength and increases the risk of labor dystocia and hemorrhage. Maternal positioning, such as upright or side lying, can help maximize pelvic diameter. Then there's shoulder dystocia, an unpredictable emergency where the shoulders impact after the head is born. The key warning sign is the turtle sign, where the head retracts against the perineum. Immediate interventions include the McRoberts maneuver, which involves hyperflexing the mother's legs, and suprapubic pressure, never fundal pressure, as it worsens impaction. After birth, you assess for clavicular fracture or brachial plexus injury and document thoroughly.
Right. Abnormal fetal presentation or position also causes problems. Rotation abnormalities like persistent occiput posterior OP or occiput transverse OT, prolonged labor, and increased back pain. Nursing interventions include hands and knees or side lying positions to promote rotation or upright positions for gravity. Deflection abnormalities, where the fetal head isn't well flexed, increase the presenting diameter, as seen in military brow or face presentations. Breech presentation slows dilation and increases risks because the head delivers last. ECV might be attempted pre-labor, but planned cesarean is typical. If vaginal breach occurs, rapid delivery of the head and shoulders is critical. Multifetal pregnancy leads to uterine overdistension and abnormal presentations, increasing risks for preterm delivery, ineffective contractions, and postpartum hemorrhage. Each fetus is monitored separately, and a full resuscitation team is prepared. Fetal anomalies like hydrocephalus can also prevent normal descent.
Next, problems with the passage can arise from the pelvis or soft tissues. A small or abnormally shaped pelvis can slow labor, obstruct passage, and lead to weak contractions and delayed descent. There are 4 basic pelvic shapes: gynecoid, most favorable; android, male type; anthropoid, oval; and platypeloid, flat. Most clients have mixed types. The most common soft tissue obstruction is a full bladder, which reduces pelvic space and impedes descent. Encourage voiding every 1-2 hours or catheterize if needed. Problems of the psyche or emotional factors such as fear, pain, or lack of support can impair coping and interfere with progress. Physiologically, stress increases glucose consumption, catecholamic secretion, inhibiting contractions, and diverts blood flow from the uterus. Nursing measures include building trust, creating a comfortable environment, encouraging relaxation, offering accurate information, and providing pain relief.
Abnormal labor duration also brings its own set of risks. Prolonged labor increases risks for maternal or neonatal infection, exhaustion, and anxiety. Nursing measures include promoting comfort, conserving energy, position changes, and assessing for infection. Precipitous labor, defined as birth within 3 hours of onset, carries risks like placental abruption, fetal hypoxia, meconium, lacerations, and postpartum hemorrhage. Your nursing care priorities here are to promote fetal oxygenation, side-lying, oxygen, 5E fluids, stop oxytocin, support maternal comfort, and remain at the bedside for emergency birth.
Let's apply the nursing process during dysfunctional labor, focusing on specific problems like possible intrauterine infection or III. Your assessment involves monitoring maternal temperature every 2 hours in labor and hourly after ROM, watching for fetal tachycardia, over 160 beats per minute for at least 10 minutes, and evaluating amniotic fluid. Clear fluid with a mild odor is normal. Yellow, cloudy, or foul-smelling fluid suggests infection. Other suspicious findings include a white blood cell count over 15,000 without steroids, or purulent cervical fluid. Remember, fever alone does not equal III. It requires maternal fever plus at least 1 additional finding. Your planning aims for a maternal temperature below 38 degrees, FHR without persistent tachycardia, and clear amniotic fluid. Interventions include reducing risk through meticulous hand hygiene, limiting vaginal exams, maintaining aseptic technique, and keeping underpads dry. Identify early by increasing assessment frequency with prolonged labor, or ROM, and timestamp the ROM duration. Notify the provider promptly, obtain cultures before antibiotics, and alert the newborn team. Evaluation is successful if temperature, FHR, and fluid remain normal with continued surveillance.
For maternal exhaustion, assessment includes reports of fatigue, frustration, or diminished coping, often with fluctuating vital signs. The problem is identified as exhaustion related to prolonged, unproductive labor, high energy demands, and limited rest, nutrition, or hydration. Planning aims for restful intervals and effective coping. Interventions focus on conserving energy by lowering lights, minimizing noise, and maintaining comfortable temperatures. Position for physiology and comfort with frequent repositioning, peanut balls, and sacral counterpressure. Ensure hydration and fuel with 5E fluids and clear liquids if allowed. Promote coping by explaining rationales, coaching and praising efforts, and offering updates and analgesia options. Evaluation successful if the client rests and demonstrates coping.
Now, let's focus on premature rupture of membranes, or PROM, which is ROM before labor onset, and PPROM, which is ROM before 37 weeks. The etiology and risks include vaginal or cervical infections, weak membranes, prior PPROM or preterm birth, cervical insufficiency, uterine overdistension, and maternal stress. Complications are maternal and neonatal infection, oligohydramnios, leading to cord compression or reduced lung volume, and prematurity risks. Risk rises with prolonged ROM. Therapeutic management involves confirming ROM with a sterile speculum exam, pH for testing, or PAMG1 assays, avoiding digital exams. For term or near-term clients, induction is usually recommended. For preterm clients, expectant inpatient management is common if no infection, including daily NSTFHR monitoring, antenatal steroids for lung maturity, and latency antibiotics. Taucolysis, which uses medications to relax the uterus and temporarily stop contractions, is short-term, only to complete steroid courses.
Okay, your actions here are paramount. Do not perform routine digital exams in suspected prom-prom. Use a sterile speculum. Start antibiotics after cultures, but don't delay therapy for unstable clients. And with fever plus fetal tachycardia or abnormal fluid, escalate promptly, anticipating OB and pediatric team involvement. Now, for preterm labor, defined as labor after 20 weeks and before 37 weeks. While maternal risks are similar to term labor, the newborn faces the greatest risk, especially before 32 weeks, for things like respiratory distress syndrome, RDS, and neurodevelopmental delays. This is also a critical health equity issue with marked disparities, especially among Black infants. We must address barriers to care, transportation, language, childcare, insurance, mistrust, and advocate for community fit models to improve access and outcomes. The risk landscape is multifactorial, with over 50% of cases having no identified risk factor, but infections, uteroplacental ischemia, uterine overdistension, cervical factors, maternal conditions, and social determinants all contribute. Early recognition is challenging because symptoms are often subtle, mimicking normal pregnancy. Contractions, cramps, backache, pressure, or a change in discharge. At triage, treat vague, persistent symptoms seriously, and don't delay evaluation while waiting for classic active labor signs.
Right. For prevention and education, it's about empowering clients. In the community, this means educating on normal pregnancy length, the consequences of preterm birth, and subtle signs of preterm labor. During pregnancy, rescreen risks, reinforce signs, use teach-back, and provide home self-care guidance, such as hydration and position changes. Encourage clients to come in if unsure. Early evaluation creates a window for crucial interventions like steroids, antibiotics, or transfer. Prediction and screening involve transvaginal cervical noth measurement, a length of 25 millimeters or less increases risk, and FFN PAMG1 assays, which are useful when negative.
Management goals are to identify those truly at risk, delay birth when safe to enable lung maturity, neuroprotection, and transfer, and treat underlying causes like infection. Initial measures involve ruling out contraindications, promptly treating infections, and individualizing activity modification, avoiding routine bed rest. Your priority here is to minimize digital exams and use a sterile speculum if ROM status is uncertain, and to start the ROM clock once confirmed. Tocilizumab, used between 23-34 weeks, aims to buy 48-72 hours for steroids, GBS prophylaxis, Group B strep, transfer, and magnesium sulfate for neuroprotection. Magnesium sulfate requires close monitoring of respiratory rate, urine output, and deep-tended reflexes, with calcium gluconate, the antidote, at the bedside. Difidipine, a calcium channel blocker, can cause flushing, headache, and hypotension, requiring orthostasis precautions. Indomethacin, a prostaglandin synthesis inhibitor, has maternal GI side effects and fetal risks like ductus arteriosus constriction. Terbutaline, a beta agonist, is for short bridging use only due to a black box warning for prolonged use.
And antenatal corticosteroids are given if birth is expected within 7 days, between 24-34 weeks, to promote lung maturity, with maximum benefit if given at least 24 hours before birth. You'll monitor vital signs and lung sounds for pulmonary edema. Magnesium sulfate is also used for fetal neuroprotection for those less than 32 weeks. Your nursing checkpoints and safety nets include immediately escalating any new fever, uterine tenderness, foul fluid, or fetal tachycardia. Avoid routine bed rest, document timelines precisely, and maintain an equity lens. Okay, let's do a quick teach back for you, our listeners. What are 3 subtle signs of preterm labor? Why do we give steroids and magnesium sulfate in PTL? What's one nursing priority to reduce infection risk in suspected prom? Which tocolytic needs calcium gluconate on standby? And why is routine bed rest no longer recommended? Thinking about these will really solidify your understanding.
Yeah, that's a good exercise. Now let's get into the application of the nursing process for preterm labor. It's a blend of high-acuity clinical management and family-centered psychosocial support. Your assessment covers maternal fetal status, including contraction patterns, cervical change, ROM timing, temperature, vital signs, and FHR, watching for tachycardia with fever or triple I. You're also assessing medication effects, infection risk, and psychosocial factors like coping, support networks, and financial strain. Minimize digital exams and use a sterile speculum for ROM verification, initiating the ROM clock once confirmed. Client problems typically include physiological risks like infection, preterm birth progression, medication adverse effects, and fluid overload, as well as psychosocial issues like apprehension, anxiety, and potential anticipatory grief. Planning aims for physiological stability of febrile status, reassuring FHR, and ideally delaying birth for 48-72 hours to complete steroids and GBS prophylaxis. Psychosocially, the goal is for clients and families to identify coping strategies and demonstrate teach-back on warning signs.
For interventions, you'll reduce infection risk by meticulous hand hygiene, limiting vaginal exams, and maintaining aseptic technique. Trend vital signs and FHR more frequently, obtain cultures before antibiotics, and position for optimal physiology with side lying and oxygen as ordered. Medication management involves careful titration of tocolytics, meticulous monitoring of magnesium sulfate with calcium gluconate at the bedside, and vigilance for side effects of nifedipine, indomethacin, and terbutaline. Administer corticosteroids per gestational age and monitor for pulmonary edema. Precisely time-step medications, ROM, fever onset, and transfers, these details drive crucial neonatal and obstetric decisions.
Absolutely. Family education and coping support are crucial. Provide clear, paced information using interpreters and teachback, normalizing feelings and activating resources like social work. Set expectations for potential NICU care. For home or activity guidance, individualize activity modification, not routine bed rest, and emphasize hydration, bladder emptying, and avoiding vaginal insertions or nipple stimulation if preterm. Teach daily temperature checks and warning signs. For preventable and ethical considerations, facilitate balanced counseling with a multidisciplinary team, align interventions with family goals, and prioritize care at high-risk maternal neonatal facilities. Evaluation assesses whether physiological goals are met, infection is controlled, and the client and family articulate coping strategies, warning signs, and follow-up plans. Escalate care if goals are unmet.
Now let's briefly discuss post-term pregnancy, which is defined as 42 weeks or more. Most pregnancies are induced before this point due to reliable dating. The principal danger is placental insufficiency due to aging, which limits oxygen and nutrient transfer. This can lead to fetal intolerance of labor, oligohydramnios, meconium passage, and, if growth continues, macrosomia, with risks for shoulder dystocia and postpartum hemorrhage. Fetal mortality rises after 41 weeks. Management involves confirming gestational age, assessing fetal well-being with NSTBPP and amniotic fluid volume. If reassuring, expectant management with close surveillance may be reasonable, otherwise induction of labor is indicated.
Your priorities for post-term pregnancy are to teach fetal movement counting and explain antepartum tests. You'll prepare and support the client for induction, including cervical ripening options, and acknowledge and manage the psychological toll of prolonged pregnancy, offering coping strategies and clear timelines.
Finally, we arrive at intrapartum emergencies. These are high-stakes situations that demand immediate, coordinated action. Placental abnormalities, like placenta accreta, involve abnormal adherence of the placenta, often linked to prior uterine surgery, and carry a massive hemorrhage risk. Management involves early imaging, multidisciplinary planning, large-bore IVs, and cross-matched blood, with a C-section and possible hysterectomy. Your nursing focus is hemorrhage readiness, e.g. administering TXA, a tranexamic acid, and preparing for massive transfusion protocols, MTP, invasive line care, strict intake output, and post-op critical care.
Then there's prolapsed umbilical cord, where the cord slips below the presenting part after ROM and is compressed, causing time-critical fetal hypoxia. Risk clues include high fetal station or malpresentation. Recognition is key. A visible or palpable pulsating cord or sudden FHR bradycardia or variable decelerations after ROM. Immediate actions are critical. Do not wait. Call for help, activate the response, and immediately relieve pressure on the cord by positioning the client in knee-chest, Trendelenburg, or side-lying with hips elevated, and manually elevating the presenting part off the cord with a gloved hand until delivery. Avoid handling the cord. This can cause vasospasm. Consider oxygen and administer a tocolytic if ordered. Expedite delivery, which is usually an emergent cesarean. Your nursing focus is to maintain elevation during transport, provide concise reassurance, prepare the OR and neonatal resuscitation, and document times and interventions precisely.
Uterine rupture is a tear in the uterine wall, often at a prior scar, leading to hemorrhage and fetal compromise. Risks include prior classical uterine incisions, excessive tachysystole, or obstructed labor. Warning signs are sudden abdominal pain like something ripped, chest or shoulder pain, loss of fetal station, cessation of contractions, shock, often with limited external bleeding, and non-reassuring or absent FHR. Management involves rapid recognition, resuscitation, and emergency laparotomy or cesarean. Your nursing focus is high vigilance in TULAC or hyperstimulation, titrating or stopping uterotonics with tachysystole, and preparing for a stat or and massive transfusion. Postpartum, suspect rupture with heady bleeding despite a firm fundus.
And uterine inversion, where the fundus turns inside out, typically during the third stage, causes massive hemorrhage and shock. Triggers include premature or excessive cord traction or atony. Findings include an absent fundus abdominally, a red beefy mass in the vagina, severe pelvic pain, and rapid hypovolemia. Management involves immediate uterine replacement, often under anesthesia, followed by uterotonics once replaced. Anticipate large volume transfusion. Your nursing focus is hemorrhage protocol, large bore IVs, MPO, Foley for IO, frequent vital signs, remembering BP drop as a late sign, and critical observation. Across all these emergencies, the clinical through line for nurses is consistent. Recognize early, escalate fast, stabilize while preparing definitive care, communicate simply and supportively, and document meticulously.
When facing intrapartum emergencies, the psychosocial aspects are often overlooked in the moment, but they're critical. Emergencies erupt suddenly, and you can expect narrowed attention, fear, and a profound loss of control in the client and partner. There's often a mobilizing anxiety and a limited capacity to process complex explanations, all while concurrent neonatal needs are unfolding. As you initiate stabilizing actions, you're simultaneously assessing maternal ABCs, hemodynamics, pain, and their level of understanding, alongside fetal status and family cues. The primary client problem here is acute apprehension related to the sudden complications, with potential for grief if fetal or maternal outcomes are threatened.
So how do we support them in these intense moments? Your planning aims for the client and family to indicate a basic understanding of what's happening and why, and to have opportunities to express feelings and debrief when stable. Your interventions involve communicating, stabilizing, and supporting simultaneously. Explain simply and honestly in short phrases while you work. I'm lifting the baby off the cord so more oxygen gets through. Or, we're moving to the OR to deliver quickly. Include the partner when feasible. Provide continuous reassurance and presence, staying at the bedside, using a calm tone, and therapeutic touch if welcomed. Orient the family to the team, identifying roles and stating where the baby is going. Balance information with bandwidth, keeping messages brief during high anxiety and offering fuller explanations later. Support coping and safety by ensuring the partner has a point of contact and offering chaplain or social work services. And document meticulously times, assessments, actions, notifications, responses, teaching, and concerns.
Evaluation is deferred until the client is medically stable, but outcomes are met when the client and family can restate, in their own words, the nature of the complication and the rationale for emergency procedures, and begin to voice feelings. Providing debriefing and connecting them to resources is crucial.
Exactly. In intrapartum emergencies, timely clinical action saves lives. Steady, simple communication preserves trust. Both are nursing, and both are equally vital. Hashtag tag outro.
Wow, what an incredible deep dive into the complex world of intrapartum nursing. We've covered everything from welcoming a family into the birth center, distinguishing between types of labor, optimizing positions for birth, to navigating high-stakes interventions like version, induction, and even emergent operative deliveries. We also journeyed through the critical fourth stage and the many complications you'll be ready to address, like shoulder dystocia, placental abnormalities, and even uterine rupture.
What's truly impactful here, and what we hope you take away, is the sheer breadth of the nurse's role. You balance technical skill with compassionate presence, ensuring physical safety, promoting early attachment, and providing unwavering emotional support through one of life's most significant events. You are the front line, the advocate, and the constant presence.
For you, stepping into this field, understanding these nuances, from why a peanut ball helps to recognizing the subtle signs of preterm labor or the critical actions during a cord prolapse, isn't just about passing a test. It's about building the confidence and competence to be that indispensable guide for clients and their families.
Think about this. In a world of increasing medical complexity, how does the art of nursing presence, that human connection and emotional support, become even more critical than ever before in shaping a positive and safe birth experience, especially when complications arise?
Keep that question in your mind as you head into your clinical rotations. The deep dive into intrapartum nursing care and complication management continues every day in practice. We can't wait to see the difference you'll make. Thanks for joining us for this deep dive. We'll be here next time, ready to unpack another stack of sources just for you.